Welcome to Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, JJ Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Welcome, everyone, to today's episode. I'm thrilled because we're exploring a critical topic, rehabilitation for individuals with multiple sclerosis. This field has evolved so much, and I'm thrilled to have a leading expert with us, Dr. Herbert Karpatkin. He's truly passionate about helping people with MS thrive, and I can't wait for us to hear his insights. Welcome, Herb.
Thank you, JJ. It's really wonderful to be here. Thank you for this opportunity to talk about one of my favorite topics, physical therapy for persons with multiple sclerosis.
Well, I love it. Now, could you get us all started? I want to know a little bit more about you.
Well, I've been practicing since the 1980s, almost exclusively in rehab. I made the transition to focusing on multiple sclerosis in the early 90s when I had the opportunity to work with a physician who was one of the leaders in the field, Dr. Joseph Herbert, who challenged me to be a multiple sclerosis physical therapist. Like a lot of physical therapists, I had very, very little training in MS when I was in PT school. And the overarching idea was that persons with MS were not good rehab candidates for various reasons, usually having to do with fatigue and thermosensitivity. Dr. Herbert challenged me to reject that wrong idea, reject that myth. And since then, I've been on a mission to try and make physical therapists more aware of the fact that persons with MS are actually excellent rehab candidates. You just need to understand the mechanism behind their disability a little bit better.
Outstanding. And it's just so important. Now, where are you at right now? Because I know that you teach.
Sure. Right. I'm an associate professor of physical therapy at Hunter College, City University of New York. That's my primary job. I teach courses in neurologic evaluation and treatment, courses in rehab and research design, teach courses in gerontology. I'm a GCS as well as an NCS.
Okay.
And teach courses in bioethics and psychosocial aspects of healthcare.
Holy crow. Yeah, you're showing up. That's really impressive because that's
also
not an easy thing.
Most importantly, I'm also a practicing clinician. I literally came from seeing a patient with MS to get to this talk.
Oh,
I see patients every day.
Well, they're very, very, very lucky to have you. So I'm so excited. Thank you for taking time out of your busy schedule. But I knew you were the man that I wanted to talk to about all of this. What do you think, Herb, from the standpoint of if there's anything we should be questioning as clinicians in regards to people with MS?
Certainly. I think a lot of the misunderstandings that clinicians may have from MS comes from a lack of a full understanding of the pathophysiology of the disease. The pathophysiology of MS is very different from that, say, for stroke or spinal cord injury or TBI or Parkinson's or anything like that. So the treatments that are effective for those other diagnoses will not be as effective in MS. The key difference in MS is that the disease presents with fatigue and related thermosensitivity. This means that when they exercise, they fatigue more quickly than in other diagnoses, and this limits the dosage or volume of exercise persons with MS can perform. As a result of this, clinicians will often give insufficient amounts of exercise to MS patients. And so a lot of my research is based on trying to find ways to increase that dosage.
Yeah, I really appreciate. I know when I was in school, I did learn about thermosensitivity. Essentially, all they said was just don't let them be overheated. But it seems that, and so hopefully we can talk more specifics about that. But recently, I feel it's just been recent where the fatigue part and the importance of fatigue and, addressing fatigue and measuring fatigue and finding other ways to help them with their fatigue, that seems to be more emphasized recently, or is that just me?
No, that's correct. And I'm really pleased about that because we're beginning to realize that fatigue is, fatigue in multiple sclerosis is multifactorial. Fatigue is not one thing, it's many interacting things. It's also, as a little bit of a side, fatigue is a factor in many other neurologic conditions, but none so much as multiple sclerosis. So there's two distinct types of fatigue in MS. There's what's referred to as objective fatigability, which is a worsening in physical performance over time, and that is what I'm the most interested in as a PT. And then there's subjective fatigue, which is simply a subjective feeling of tiredness. The person may physically not be performing poorly, but they'll feel so tired they can't go on. And a person with MS can have one or the other or both. Okay? There's also the difference between primary and secondary fatigue. Primary fatigue is due specifically to the disease. And in the case of primary objective fatigability, this is directly related to the thermosensitivity. There is a phenomenon that's referred to as activity-dependent conduction block, which simply refers to the fact that as the body's core temperature increases in heat, there is a worsening of transmission through demyelinated nerves. What happens during exercise? Core temperature increases. So as core temperature increases, there's decreased function because there's decreased transmission through these demyelinated nerves. So you have this conundrum that they need more exercise, but when you exercise them, their body heats up and that makes their symptoms worse. So a lot of my research is based on trying to find ways to avoid the heating up.
Okay, so just to recap, make sure I'm oriented here. So the heat sensitivity, again, you have decreased conduction, and then that's resulting in which fatigue? The objective?
Correct. Okay. So persons with MS, they exercise, their core temperature increases. As a result of the increase in core temperature, there's decreased transmission through demyelinated nerves, resulting in poorer physical function, or cognitive function for that matter as well.
Okay, so both. And we know that definitely impacts them. And so from that standpoint, when you look at what the recent research says, so the fatigue and the heat sensitivity are going hand in hand.
That is correct.
Okay. And so from what does the recent research say in regards to or your research of how to address that? Is that what you're looking at?
That is very specifically what my research is looking at, and we're trying to come up with ways to minimize the fatigue as much as possible so that a larger dosage of exercise can be obtained by these patients. So the simplest thing to do is just to cool the patients off. We have a study in press right now where we simply gave persons a cooling vest persons with MS, a cooling vest. They wore it for 30 minutes, and then they would do a 6-minute walk. A few days later, they would come back. They would do the same 6-minute walk, but without a cooling vest. And the 6-minute walk test performance was significantly different when in the pre-cooled condition compared to the uncooled condition. It simply kept their core temperature lower so that the thermosensitivity was forestalled. We're also in the middle of data collection right now where we're using a similar model where we're doing pre-cooling before a balance test. We're using the mini best test, and we're finding persons who were pre-cooled before doing the mini best test are having better performance on the mini best if they were pre-cooled as opposed to an uncooled condition. So it's pretty clear that cooling is going to improve physical performance in persons with MS for both gait and balance.
Well, I absolutely love those studies. And I know that in the past, people have said, okay, when they get hot, cool them down. And I'm like, And I've always told people, don't wait that long. Like, do it pre, but I'm not sure that I've done it. Like if it was hot outside and they came in, I would do it right away before we even did activities. But if it wasn't, I'm not sure that I made it a consistent, I know I didn't make it a consistent piece of cooling them, and I definitely didn't cool them for that long. Is 30 minutes?
30 minutes, we just used that because it was suggested by other studies. But before I started teaching at Hunter, I had a outpatient practice that tried to specialize in persons with MS. And we had a lot of cooling packs and a lot of air conditioners and a lot of fans. We tried to keep people cool. The second they came in, we might actually tell them to come in a few minutes before their appointment, wear a cooling vest for 10 or 15 minutes, then start working while they were recovering. They would take rest breaks during the PT session, and we'd put the ice vests back on them. And then when they were done, we might cool them off some more so they could recover more quickly. So I have never found a problem with overcooling someone. You can get them too cold. I mean, you don't want to stick them in a meat locker for a day or two, but 20, 30 minutes with a cooling vest, or giving them a cold drink to sip while they're working, or just pointing an air conditioner at them is going to improve their physical performance.
And I really love that idea. I tell people that, like, if your patient can come in 10, 15 minutes early and do something that doesn't take skill, positioning them on the mat so that they can stretch a certain muscle.
Excellent.
And so the cooling thing to me is exactly like that. You
exactly
ask them,
correct.
It's part of their session. I mean, you're not billing for that, but you're asking them, you're going to come in at this time, you're going to sit wherever, or even lay down because you want a certain stretch at the same time, or a stretch of the chest and some breathing, and cool them off at the same time.
I think that's excellent, JJ. That's exactly what I would be doing. I think
so let me ask you.
Go ahead, please.
Sorry, just from the cooling, because I've always been like a cooling vest person. I know there's some that you put in. There's some that people have made so that they could wear underneath their clothes. But then you hear these things. I always like cooling the neck too. And then someone said, no, you should never cool the neck. You should cool the hands. And then someone else said, no, don't cool the hands. You should cool the feet. And I'm like, do you have any strong opinion?
Cool. So here's my take on all that. The difference between cooling the hands and cooling the chest or something is like that. The difference between cooling and not cooling is like that. There's been one study that showed reflexive cooling that people had good responses just by cooling the hands. It's a nice idea. It means they didn't have to wear the vest. Using a cooling cap has worked. I've never heard any problems with cooling the neck. A lot of my patients have like this scarf thing, that the cooling scarf they wear around their neck works great for them. I think it's just getting them to do some type of cooling, I don't care what it is going to enhance performance.
Beautiful. You can even make it, and I just saw a new one where it's like the gel pack in a U that you put around your neck.
Yes,
when
I saw
you're
that.
Outside.
Perfect.
Yeah, I bought it for me so that, because when I get hot, if I'm treating outside or whatever, and I was just thinking that you could have 3 or 4 different options and then say, hey, we're going to try this one for a little bit, try this one, and then let them pick. Add some autonomy in there.
I want to emphasize, as long as you're doing some cooling, it's going to have a really positive outcome. It matters more to me that they're doing cooling than the type of cooling that they're choosing to do.
And the time frame, you're good with 15 minutes? Are you good with 20 minutes? What would be your dream time?
I'm glad you asked that, because I can't answer it. There is such profound variability in MS patients that some people may be great with 5 minutes. Some people may be great with 30. Some people may not be able to tolerate 30. So for the study, we did 30 minutes because we wanted to have consistent application of variables. But generally, I'll generally do 15, 20 minutes, or I'll just ask the person, you feel ready to go? There's no evidence which tells you that 10 minutes is better than 20 or 20 is better than 30. It's going to depend on many factors, including but not limited to the degree of disability, the task that you're asking the person to do, how cold sensitive the person may be. Someone who has a lot of, say, extra adipose tissue may require more cooling than someone who's very, very lean and small. So there's going to be a lot of variability. One of the things I've learned through my years of working with MS is the saying, if you've met one person with MS, you've met one person with MS. There's such profound variability, not just patient to patient, but within patients, that it's hard to come up with stereotypical rules to follow.
And I appreciate that so much, Herb, because I think that we just need to be nicer to ourselves as therapists. I know I consistently say that, but everyone is so different. So just pay attention to when you say they responded well. So, but just have them part of the decision making.
Always.
Stress yourself that, what's the right answer? Like the cooling of the neck, or this, or that's wrong, or this is wrong. Like you said, I just love the comparison. Little cooling or a lot of cooling. Like cooling, you need to cool them.
Cooling, yeah.
And for a certain period of time, and then you guys together figure out the time, and whatever time they say is the right answer. When you think of it.
Yeah, but I'll let the PhDs of the future figure out, what's the optimal cooling time and garment, things like that. Right now, I just want people to cool.
And as soon as they say the optimal time, someone's going to come along and they're going to find a study that shows that that's not true. So I just appreciate that so much. And I just think it's just a great reminder. All therapists, from what I'm hearing you say, make sure that we're cooling before they're getting hot, before they're working out.
Right.
You're
pre-cooling.
You're prepping them.
Pre-cooling.
That's right. Good. I love that. So it sounds like if we're talking about patients or conditions, it's going to vary, but no matter what, cooling. So what are the things in regards to translating some of that research into
Sure. So the greatest amount of my research has been looking at what we call intermittent training, or intermittent exercise. And to be perfectly honest, this comes from my background. Before I was a PT, I was a track and field coach. And as a track and field coach, I would have my runners improve by doing interval training. They would run a fast quarter mile and then, recover for a minute or two and then run another one. This would, again, allow them to do a greater volume of running at a faster pace. In persons with MS, I use a similar paradigm. If you ask a person with MS to walk as far as they can without stopping, they'll say maybe walk 15 minutes and then their fatigue and thermosensitivity will be too great. And that's as far as they can go. They can't surpass that. They'll never get a bigger dosage by walking continuously. But what if instead you had them walk for 3 or 4 minutes at a time and then rest, and then 3 to 4 minutes at a time and then rest? So in those rest periods, their core temperature goes back down. And that allows them to avoid some of the fatigue and get a much bigger dosage of exercise. So I've seen in so many of my patients, I have them do, as part of initial evaluation, what I call a collapse point walk. They walk as far as they can, and then when they feel they really can't walk any further without great difficulty, they stop. And say if their collapse point is 15 minutes, I will give them an exercise program where they'll do multiple walks of, say, 3 to 4 minutes, but the sum total is going to be a total of 20 to 25 minutes. So the dosage is much greater.
Okay.
The way I like to explain this is I think of exercise in a similar way that I believe physicians may think about medication. For a medication to work appropriately, optimally, you have to take a certain dosage for it to reach its therapeutic level. I think it's the same thing for exercise and physical therapy. In order to get the therapeutic level of exercise, meaning to have it give its best response, you need to give the optimal dosage. And I think in MS, we really miss that dosage.
They're very underdosed.
I think yes, agree completely. We are completely underdosing our MS patients.
Now, let me ask a couple questions. So,
please.
I love that collapse point. It's just very descriptive. So, they're going, you said 3 or 4 minutes until they hit a collapse point. Now, is the 3 or 4 minutes, let's just say walking, is that as hard as they can walk, or is that just, I'm going to walk for as long as I can? Do you know what I mean? Comfortable versus fast.
Sure. the answer to your question is yes. I will do.
Okay.
I will do both. Generally, I will, if it's somebody who is just trying to increase the distance that they walk, I will tell them to walk at their best comfortable pace. But some patients who want to really improve their speed as well, I will do the exact same thing. I will say, okay, walk at this pace as fast as you come, really fast. And when you lose the speed, and I'll be perhaps, timing them, okay, then that would be their collapse point. I'm much more likely, though, probably because I tend to work with more disabled patients, to just do at their best comfortable pace instead of their best pace. But it works just as well either way.
But I like what you're bringing up. What's the patient's goal?
Yes.
Is the goal to go out to the park with their grandkids and walk, or is their goal to get to the piece of whatever they're buying at the sale? They need to get there fast and get out or whatever.
JJ, I'm so glad you brought that up, because I think more physical therapists need to look at that. We have these great outcome measures, the 6-minute walk test, etc. But the purpose of PT is not to improve 6-minute walk test performance. The purpose of PT is so that the patients can use walking to accomplish the goals, be it like walking their daughter down the aisle for the wedding, or walking to the corner store to buy a cup of coffee and walk back. The patient doesn't really care about the 6-minute walk test. The patient wants to be able to walk again as part of their normal life. And so that's why every single patient I see, the final goal for me is what they tell me it is. They say, I need to be able to do this. So my job is to help them be able to do that.
Yeah, definitely quality of life. It's about their quality of life.
Yeah.
And so I absolutely agree with you. And I think that's so important when we're taking this research and we're trying to translate it into the clinic. It's just so important that we're taking that into consideration. And so I think some of this, so when you're looking at their collapse point, are you also looking at heart rate? Are you looking at RPE? Are there other of your favorites that you're incorporating?
All of the above. So firstly, I do look at heart rate. The problem with heart rate is MS can often impact the autonomic nervous system. So you may not be getting an accurate reading of their heart rate being representative of their level of how hard they're working. I will always take it, but I'm not sure I'm getting a true reading. I will do RPEs, but again, a lot of times because of subjective fatigue, they may say they're really tired, but they may still be trucking along. What I tend to look at instead, mostly, is I will just observe them, and I will see is their walking deteriorating at all. So, for example, patient I saw a few days ago, we were doing a 6-minute walk, and she was doing just great in the first minute and the second minute, and in the third minute, she kept up her pace, but she developed a foot slap, and as the walk went on, the foot slap became more audible. By the 5th minute, she developed, in addition to the foot slap, an extension thrust and was actually even starting to circumduct a tiny bit. And she had slowed down minimally, but she had started to compensate to make up for the weakness and fatigue in the leg that was the most affected. So you can use heart rate, you can use RPEs, but what I really like to do is watch them. Once I see the foot drop, I know that activity-dependent conduction block is starting to occur. And then I will, at that point, say, can you correct? You're slapping your foot. Can you correct that? And if they can, I'll have them keep going. If they can't, I'll know it's time to stop.
Well, I'm just so glad you said that and reiterated it, because that really goes back to the pathophysiology, right? This isn't something where you're just going to push them through that. You need to have your clinically reasoning eyes on them and be able to note those things and document them to justify the care, because again, this kind of all comes together, right, in regards to justifying so you can keep people longer for therapy and we can understand the importance. And so putting those pieces together seems so important.
Right. And I want to reemphasize what you said. Unlike with other patients, you can't tell persons with MS, don't give up, push through the wall, break through. Not going to happen. The mechanism of their fatigue is going to prevent it from happening. There's no question that they can improve, but they're going to improve by taking breaks. I like to say to my patients, the more breaks you take, the more work you can do. So take a lot of breaks so you can do more work.
The more breaks you take, the more work you can do. Okay. I want to write that down. The more breaks you take, the more work you can do. Just because I think we need some of those specific sayings, and how do we get our patient on board with this? How do they understand, the education is so important with this population. The more we understand, the better we can be clear with why are we doing it this way, and why is this so important, and why do we care about what we're seeing here, and how what we might learn for one patient diagnosis isn't going to just cross over to this unique presentation.
Right. And I'm really glad you said that. I consider one of my primary roles for my patients is to be an educator of them, to make sure that they learn about MS from me, about the role of exercise in MS. So that's a very important point for our profession.
You're just amazing. That just is so important. And thinking about, okay, so now I'm thinking about this big picture of the clinician tomorrow who's going to go in and they see a new person. I want to go back for a second to the fatigue. Like, is there a fatigue measure, or, I know there's a few out there. It's just because I remember last CSM, there was a couple the last few CSMs, there were some presentations on fatigue scales. And I know last time I looked, there was a couple different ones. Do you have ones that you like, or when do you use them?
Yeah. So again, it depends on what you want to measure. A lot of the fatigue scales out there are for subjective fatigue. How tired do you feel? And a lot of the ones that are commonly used are really measuring the impact of fatigue on various tasks you performed over the last week. That's not helpful to me so much as a physical therapist. I want to know, how fatigued are you while you're performing this specific task, this walk, this balance task? So what I will often use is something that's called the visual analog scale of fatigue, which is just what it sounds like. You have a 100 millimeter line, and I tell the patient at 0 millimeters is no fatigue at all. 100 millimeters is the most fatigue you can experience. Draw a line as to where are you now. Then exercise a few minutes, draw a line as to where are you now. And you can measure that distance in millimeters, and it becomes a nice research tool. But again, not necessarily that helpful, because you're still just measuring subjective fatigue. So my way of measuring objective fatigue is to give them a fatiguing task and see how they do on it. So in one of my studies, I pointed out that if you give a person with MS a continuous 6-minute walk, the majority of them, their first minute will be the fastest, the second a little slower, the third a little slower, et cetera, et cetera. And you'll see this slowdown, this almost linear slowdown over time. In normal populations, you'll often see, so-called normal populations, you'll often see what's called the hockey stick graph, because the line, you see persons sprinting at the finish line, they speed up towards the end. In MS, it's often the opposite. And again, this is activity-dependent conduction block. So I will use a 6-minute walk test as a way of measuring fatigue. Let me talk a little bit more about the 6-minute walk test, because it's really one of the most important tests for persons with MS. If you use a really brief walk test, say a 25-foot walk test or a 10-meter walk test, you're going to get a lot of false negatives with that. You're going to look at how they do for 25 feet and say, well, that looks great, no problem with their walking. And that's often completely wrong, but it's too short a test to really uncover what's going on. The tests need to be provocative. They need to delve into the fatigue of the patient. And I have videos where I've shown persons at the beginning of a 6-minute walk, and they're just striding away, no problem. By the 6th minute, they're really struggling. So to really understand the impact of fatigue on them, you have to make sure they're tired when they exercise. Here's another example. I may do a balance test, say such as the Berg balance scale, at somebody at the very beginning of an evaluation. Then after 30 or 40 minutes later, I'll test it again. And almost always it's going to be a few points lower. So fatigue is going to have this impact on all persons with MS, and to really understand that impact as a physical therapist, as a clinician, you need to test them in a fatigued and a non-fatigued way. If you only test them when they're at their freshest, you're getting a very incorrect picture of how the MS is really impacting.
Okay, so I love this so much. For one thing, it kind of reminds me of like people with Parkinson's when they're on medication and when they're off medication, and how you really need to know both. And I would say, and it is a little counterintuitive, so I really want to emphasize this point, because I hear I'm a 6-minute walk person. I don't care if they're in acute care. Do the 6-minute walk. I mean, it takes them 6 minutes to go.
It takes 6 minutes
anyway. Yes. But like push that one, and people are like, oh, but they could get too tired, so I want to do the 2-minute. And I'm like, but they can rest. Like they can stand and rest in that 6 minutes. So we need that longer piece. And so I think the point of just reinforcing you need them to fatigue to get the information that is going to be most beneficial for them. And it's kind of like why I like the 60 seconds sit to stand versus 30, because there's a huge change I see in people the last 30 seconds from the first 30 seconds. And
Excellent.
It's kind of that whole endurance and trying to put all the pieces together to say, can they last? So, that's just a very exciting. I like the way that you said it, because I think that's just very impactful. So, okay. So we got that piece. They walk in, you see them, you do the 6 minute at the beginning, right? You're measuring their fatigue. You're looking at trends, right, with heart rate, RPE, and how they're moving. And then towards the end, after you do this high intensity bursts, is your preference walking? Is it other functional activities, or what do you like to do?
The functional activities are going to be based on what they need. So the BERG, for example, is a wonderful test, as is the mini BEST, or the functional gait assessment, because it tells you exactly what they're having trouble with. So you know the task that they're struggling with. You combine that with the history they've given you, that I'm having trouble walking to work or climbing stairs, so you know exactly what to work on. So there's absolutely no formula, no specific protocol for persons with MS because of the tremendous variability. So I will see what's wrong with them based on my evaluations. I'll look for the impact of fatigue always. I'll have them tell me what are the things that's really troubling them. I'll try to determine if there's any specific underlying impairments that I need to address, and the program becomes very individualized. I like to say sometimes that for every MS patient I see, I have to invent a new therapy, because it's going to be specific to them each time. But once I've accepted that, I think the therapies become much more successful. In a lot of other neurologic conditions, which are much more stereotypic, there are specific protocols to follow. I'm thinking perhaps the Move Big for persons with Parkinson's, and although I'm not an NDT or PNF guy, there's specific protocols followed for those as well. You really can't do that with MS. There's just far too much variability. You have to have individualized, task-specific programs for these patients. And to be honest, that's another way of dealing with fatigue. Instead of putting a lot of their energy into doing programs that are not specifically related to their needs, which I think is really just an energy suck, make sure they work on exactly what they need to be working on. If they're having trouble with sit to stand, you work on sit to stand. You're having trouble with, balance on uneven terrain, that's what you have them work on.
So I'm loving everything you're saying here, because again, I think this reinforces points of those outcome measures are beneficial for many reasons. But another is, where do they score low? That puts them at increased risk. Find out how that you can take that activity why is it meaningful? How is it meaningful to be walking with head turns while you're trying to watch your grandkids play in the yard and you're walking through the grass? and turn that into an intervention. So then you're hitting their priorities and you're actually making it realistic, but you're utilizing the outcome measures, not just to have a score, because to me, the score is the least of what I get out of an outcome measure.
Mm-hmm.
And so I think people sometimes may feel like, oh, I'm being told I have to do the standardized outcome measure. And I'm like, you get to do a standardized outcome measure because now you can take that information and the OT can take that information, whoever's doing what, and see where are there deficits so we can go all in, because that clock's ticking and they all deserve more time than we generally have to be able to give them.
When I was first starting out as a physical therapist, which I will admit was many decades ago, when I was struggling a little bit figuring out what to do, one of the more experienced therapists told me, the better your evaluation, the more you're going to know how to treat. And that is really one of the great truisms. Your patients, if you use the evaluation to let your patients tell you what needs to be done. And so when I use the Berg or the mini best or the FGA, I know exactly what needs to be done.
Yes, I love it. Okay. So big picture, just looking at our time and wanting to hear a little bit of a case, talking maximum impact. What would be your top, and I love just asking this question, your top 3 actionable takeaways for clinicians to put into practice if you could wave a magic wand and have your dream?
Okay. Well, the first is something I actually haven't brought up yet, but I want to bring it up. The first is, don't assume that the disability that you're seeing is due to the MS. Persons with MS are massively deconditioned in a lot of cases. And so a lot of the disability that you're seeing may not be due to neurologic issues, damage to the central nervous system, but due to the fact that they're simply not as physically active as before. So let me give if I may, a quick example of that. In a study we're doing right now, we're looking specifically at patients who are at the higher levels of disability in EDSS of 7 to 8. But what we're and we're giving them task-specific training. And what we're finding is these patients are responding incredibly quickly to the task-specific interventions that we're giving them. And, I think I'm a pretty good PT, but these improvements happening in 2 or 3 days is not because I'm particularly skillful. It's because they haven't practiced them in years. I saw a nice man, a middle-aged man the other day. He said, the doctor told me to get into a wheelchair 5 years ago, and I really haven't gotten out. And back to the man, so of course he got weaker. Of course his legs got weaker. He was walking beforehand. Okay, so we're probably going to be able to get him walking again with a walker. Perhaps not very, very well, but these great improvements, his improvements in bed mobility and transfers, and it's not because we caused, a huge amount of neuroplasticity to occur in 1 week. It's because he's practicing things that he stopped practicing. So assume that a lot of the disability that you're seeing may not be due to the disease, but is due to deconditioning. And that's good news for us because we're good at reconditioning patients. This is what we're really good at. So that's the first thing. Second, take breaks. Take breaks. The more you rest, the more your patient can do. And the third, as you and I said before, don't be afraid to push. These patients are probably just massively underdosed. And so we're in the middle of a trial right now where we're comparing high-intensity interval gait training. We're asking patients to walk absolutely as fast as they can for 30 seconds, interspersed with a 1-minute sitting break. And we're comparing that to moderate intensity continuous training. We're asking patients to walk basically long and slow, 20 minutes, comfortable pace, no breaks. And we're using the 6-minute walk test and the mini best and the FGA as an outcome measure. And although you're seeing some improvements in the continuous condition, the high intensity group is not only showing remarkable improvements, but also we're not having any exacerbations. We're not having any fatigue. Why? Because they're taking breaks. Okay. So we're pushing really hard, but they push hard and then they recover. Push hard and then they recover.
Did you present that at CSM?
I presented that as a poster. The study's still ongoing. We have new data, and we've submitted an abstract for the updated data. The poster's also just been accepted at the International Gait Balance Symposium, and I have two talks at CSM in 25, and I'll be bringing up that study as much as I can at each talk.
Well, because I think I read your poster, Herb, because I literally went back and there was a woman who's had MS for a long, long, long time. And what I did was I walked her for 30 seconds. I figured out her cadence. Then we found out music that she liked. We had her go as fast as she could. And then we integrated it so she could listen for 30 seconds. And then we'd stop her and then we'd do a little rest dance out, which was just weight shifting for her. But we danced around her and then go again. And then, but the beat, she was just really going with it. So I think I was trying to take your idea and just shimmy it a little to see if she would.
The idea of it. Yeah, I love the idea of using music. Walking is a symmetrical activity, and walking has a rhythm. Music has a rhythm. We should be exploiting that more.
Yeah, so I know it was you. It was you, and I think that's what inspired me to want you here so I could hear some more about it. So this is just so exciting to me. So we got the three. So challenge your patient more. Remember about the deconditioning. So don't think that because we think, they could be chronic and so it's going to be getting worse, instead of, no, we can make them better. Like some of our other degenerative diseases too, when we think about some of that, and take breaks. I also want to make sure, because the special interest group you're involved in, that's also a great access point for people. And I really wanted to highlight that component.
Sure. I'm a member of the Degenerative Disease Special Interest Group, and although I'm pretty focused on MS, we're the group for all degenerative or progressive neurologic conditions that PTs treat. So, of course, MS and Parkinson's, but also Huntington's, Alzheimer's, ALS, etc. Would this be a place I could bring up the clinician locator map? Or
yeah, absolutely.
Okay. So one of the initiatives we're doing at the DDSIG is called the clinician locator map, and we developed that to deal with the problem of access. By that, I mean that there are lots of persons with degenerative neurological conditions, and there's a lot of therapists who have skill in treating them, and they're not getting together. And which is a tragedy in my view, because I'm very confident of the ability of PT to make a big difference in these patients' lives, but they're not getting to the right PT. So too many PTs who don't have training in MS, who are trained, say, in sports medicine or orthopedics, are treating patients with MS, and they're not, don't have the experience in working with this diagnosis. So in the map, we go state by state, and we identify people who have sent us applications providing evidence that they do have expertise in these areas, and the map is accessible to everybody. And so say we need somebody who has expertise in Parkinson's disease in Florida, in Gainesville. We go to the map, we plug in Parkinson's disease, Florida, Gainesville, and it shows us who is there. The problem with the map so far is we don't have enough PTs having signed up. There are, to my knowledge, about 250,000 physical therapists in the United States, okay? And we have about 150 people on the map. So a little bit of a disconnect there. So anyone who's listening to this, if you have expertise in MS or in any progressive neurologic condition, go to the DDSIG website and sign up for the map. You have to fill out a application. It takes about 10 minutes to fill out. It comes to me or one of my colleagues. If you provide evidence that you have expertise, your name and contact information go on the map, and it's either patients or other clinicians can contact you directly.
Oh, I appreciate that. Please, or tell a friend if it's not you and you listen to this, and you can pass along to a friend, because we really need to start aligning the best that we can, and disseminating information is really tough. And so I feel that's really, really important. Okay, we only have a minute left. So could you just give your final words of wisdom or inspiration you'd like to leave us all with?
Sure. I've been working with MS, focusing my practice almost exclusively on MS for about the last 25 years, maybe longer. And I'm 66, and I still love being a physical therapist, and I love working with persons with MS. And one of the reasons is because they are so remarkably unique. Their presentation is so highly variable. I feel like I'm always learning something from these patients. But here are the 3 things I've learned, and I don't want to over-repeat myself, but I will. First, they can improve. I've always seen that there's some area they can improve. This doesn't mean I can cure them. I'm not that good, and neither is anyone who's listening here. But physical therapy can really help these patients. How do you help them? First, give breaks. Second, assume that some of the disability that they have, a significant portion, is not due to disease activity. Third, cool them off. Okay? You will have better outcomes.
Love it. Love it. Well, that's all the time we have for today. I feel like we could talk forever.
We sure
But
could.
I want to give a huge thank you to Herb for sharing such valuable insights and clinical takeaways. This will help us all go out and treat people with MS more confidently, ensuring we never underestimate their potential. Thank you so much, Herb, for coming, and thanks everyone for tuning in.
Thank you so much for having me here. I really appreciate it.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.